We have this great program today. It's a Compass to MS Care event. We do these in rural America and underserved communities around the United States. I want to let you all know that today's event is supported by EMD Serono, Sandoz, Banner Life Sciences, Genentech, Biogen, Bristol-Myers, Squibb, Sanofi, and Novartis. That's great to hear. All these pharmaceutical companies representing what we're doing or supporting what we're doing because they know that our programs are making a great impact. So I want to thank you all for attending today. Also exhibiting today, we have Bristol-Myers Squibb, Novartis, Banner, EMD Serono, Accorda Therapeutics was going to be here. Last minute they could not. And Alexion, who you'll hear about going forward as well. Our primary speaker, Megan Weigel, is president and founder of a company called OMS Yoga, and she does a lot of other things. She's a doctor of nurse practitioning, and I'm going to let her take it away. Thank you. I'll be back in a little while. Bye-bye.
Thanks so much, Stuart. It's nice to be able to be with you virtually and to know that we can still do these programs successfully that way, and actually probably have more people benefit from them in the moment. So thanks to Stuart for being just so dedicated to this work, and Bill for getting it out there to the masses. And without further ado, I'll go ahead and start this Compass to Care program. All right, so today we're going to discuss the why, how, et cetera of MS. I'm not sure how many of you are newly diagnosed, but I never like to assume that everyone knows everything. And so that's something that you'll find at the beginning of most programs. We're going to talk about your MS team, why it's important to have one instead of ignore the other people who might potentially help you on your MS journey and where you can find them. We're going to talk a little bit about telehealth. I'm not sure how things are going in Virginia, but we're still doing a smattering of telehealth here in Florida. And, we got really good at it, and we want to make sure that we don't get sloppy. And so I'm going to give you some basic tenets about how to make the most of a telehealth visit. And then we're going to talk about emerging therapies, and then finally about healthy lifestyle, which for some reason I left out of the objectives because I think that's the most important part. So next slide. So MS, the whys, hows, et cetera. Next slide. So in brief, MS is an autoimmune inflammatory disease of the central nervous system. Your body decides to, it doesn't decide, it's presented with something that causes it to go awry or to turn traitor. And in that presentation, whatever the antigen is that it's presenting with, it looks a lot like myelin. And so the body says, well, gosh, we need to go find this and destroy it because it doesn't belong here. And so the immune system finds myelin and basically attacks it, breaks it down. This causes demyelination of the nerves in your central nervous system. And this demyelination leads to the damage that causes MS relapses and eventually MS symptoms and disease progression. The central nervous system includes your optic nerves, your brain, and your spinal cord, and you can have demyelination happening in any parts of the central nervous system. In fact, even in people who have normal appearing white matter and have MS, if we were able to take a small brain biopsy, which no one does, so we don't want to do that to people, but if we were able to, we could see that demyelination was happening even in brain tissue that appeared normal on MRI. MS affects over 1 million people in the US. We used to say that it affected 2 women for every man, but we now know it's about 3 to 4 women to men get this disease. It's associated with low vitamin D, with smoking, with the Epstein Barr virus, with obesity in adolescent females, and also with genetics. So I don't know, maybe like 10, 15 years ago, they identified a couple of genes that were associated with multiple sclerosis risk. And the International MS Genetics Consortium has now identified over 200 genes that are associated with MS risk. It's usually a relapsing, remitting disease. More rarely, it's progressive. And it is associated with a significant increase in disability progression if you have a vascular comorbidity. And a vascular comorbidity is something like diabetes, high cholesterol, cardiovascular disease, high blood pressure, peripheral arterial disease, obesity, strokes. So all of those things are bad for your brain. And when you have one, your risk of reaching an EDSS of 6 is much faster and greater than if you don't have any. And that's why I love to talk about lifestyle and empowering people to make lifestyle changes in MS, because we know that lifestyle changes affect vascular comorbidities. Next slide. So I can't tell you guys how many emails and Facebook messages and text messages I've gotten in the past, I'm going to say 4 months, about Epstein-Barr. And, oh, did you hear that Epstein-Barr is related to MS? And this is very old news, but there is new news about it. So most people in the world have been exposed to the Epstein-Barr virus. It's very unusual to find a person who does not have Epstein-Barr antibodies. What we do know that came from research from a few years ago is that having mononucleosis, which is the virus that's caused by the Epstein-Barr virus, the clinical syndrome that's caused by the Epstein-Barr virus, having mono in adolescence significantly increases the risk of MS. But being exposed to the Epstein-Barr virus doesn't mean you're going to get mono. So that makes things a little bit complicated. Well, there were several discussions around the Epstein-Barr virus, several presentations around the Epstein-Barr virus at the consortium of MS centers in Washington, D.C. a couple of weeks ago. And these are the things that we know. So Epstein-Barr causes mono. The virus itself hangs out in B cells, which you may be familiar with learning about MS. It hangs out in B cells, and it actually has this predilection for, it can have this predilection for targeting myelin. So Dr. Ashirio, who's one of the foremost epidemiological researchers in multiple sclerosis, presented his research and said MS is a rare complication of Epstein-Barr infection. The relative risk of MS is over 2-fold higher in those who've had mono. However, if you break down those who have not, who are EBV negative, there are still a few that might be at risk for MS. So we know that it's not the cause. EBV, which is the acronym for it, EBV, Epstein-Barr virus, can also cause other issues. Rarely it's associated with certain types of lymphoma and other cancers. It's associated with chronic fatigue syndrome and also with other autoimmune diseases. And the complications and associations with it are associated with certain genes. So again, we have this concert of effect that's happening. And particularly 2 HLA genes, and those genes are also associated with an increased risk for MS. So the question is, well, what if we vaccinate? Could we vaccinate against EBV and basically eradicate MS? Well, in EBV negative people, you would have to give what's called sterile immunity. So that means they could not get EBV. Just preventing mono would only reduce their MS risk. So in EBV positive people, so let's say, because of course you're going to get this vaccine at a certain point in your life, in EBV positive people, giving a vaccine to Epstein-Barr could modify the immune response and reduce the risk of reactivation and MS. And there's currently a phase 1 trial underway looking at whether or not vaccination against EBV can help prevent help lower the risk of MS. Next slide. So the bottom line is it still takes a village to cause MS. We've got viral triggers, herpes viruses, the human herpes virus 6, HHV6 is another one that has been more closely implicated in being associated with MS. We still have low vitamin D as a risk factor. We still have smoking as a risk factor, and we still have genetics as a risk factor. So which of these things can we control? Well, we can't control our genes. We're born with them, but we can do our best to control them turning on. And that's where lifestyle comes in. We can't necessarily control our exposure to viruses. We can do the best we can. And again, lifestyle measures come into play here because staying healthy impacts your immune system, including your ability to fight off illnesses. We can certainly prevent smoking, absolutely. And we can prevent low vitamin D. We can have our vitamin D levels checked. We can supplement. We can go out in the sunshine and play outside, essentially. Next slide. I wanted to talk a little bit about the immune system in MS because we're going to use it. I'm going to use these terms frequently during the rest of this talk. So autoimmunity is the failure of tolerance to self-antigens. And that means that your immune system looks around and says, myelin doesn't belong here. I'm not going to tolerate that. There is not much immune action inside the central nervous system because the blood-brain barrier, which is a form of tight junctions of cells around the brain, keeps the doors to the brain locked. But inflammatory reactions that are produced by T cells after they're presented with something that, say, looks like myelin, open these junctions of the blood-brain barrier, and then cells and proteins that should not be in your central nervous system get in. And that's when they attack myelin, they cause inflammation, they cause axonal degeneration, they affect cells way beyond myelin. We have T cells and B cells in our immune system, and T helper cells in the immune system cause a cell-mediated immune response. If there is an imbalance of CD4s, then we see more inflammatory cells, Th1 cells, and fewer anti-inflammatory cells, or Th2 cells. B cells produce an antibody-mediated immune response. They're activated by T cells, and they travel with T cells, and they produce antibodies to various things in MS, like myelin. Next slide. Other important cells in the immune system in MS are antigen-presenting cells, which in the case of the nervous system are called dendritic cells. Macrophages, which are like the garbage men of the body. In the central nervous system, they're called microglia. They clean up messes, but they also clean up things we need. So they might also look at a part of the brain that's important and say that does not belong here because they're being sent messages by the immune system that are wrong. Also, oligodendrocytes are the cells around your nerve cells that produce myelin. Next slide. So let's talk about your MS team and where you can find them. There's a lot of people on this team. Where are they? Do I really need to see all of them? You can move forward 2 slides. So comprehensive MS care has actually been studied as a method of caring for people like you living with MS. And what that means is, does it work better for me to see a general neurologist in my neighborhood and then go over here for physical therapy and over here for my MRI, and maybe my physical therapist is not well versed in the world of MS? And actually what they've studied is that when there's integrative care, it works better for people with MS. So comprehensive MS care is integrated, it's interdisciplinary, but it's self-empowered. It fulfills needs that change over time. And the goal is to diagnose and treat multiple sclerosis, prevent and alleviate disabling complications, improve functional status, and address all of the needs of the person living with MS, including lifestyle, emotional, work-related issues, not just diagnose and treat the disease. Next slide. It achieves goals by educating, assessing, evaluating, treating multiple domains, working together in partnership and shared decision-making to understand the long-term needs and the short-term needs of you who lives with MS, and perhaps even your family related to your MS care. Ultimately, to reduce the negative impacts of the disease, maximize function, minimize suffering, and reduce the use of things that might be harmful, ineffective, or expensive. And comprehensive care is really best achieved with people who are MS specialists. Next slide. Here are the domains of comprehensive MS care. Now, when you guys look at this slide, you might say, well, I have some of those symptoms, but not all of those symptoms. And I would ask you to ask yourself, are those symptoms adequately managed? Has it been recommended to you that you see a specialist for something, like perhaps a urologist for bladder dysfunction, or a gastroenterologist for bowel dysfunction, or maybe a speech therapist for cognitive rehabilitation. And you've said, no, way too many doctor's appointments already. I don't need to see people like that yet. Can't you just help me, neurologist or MS nurse practitioner? And the answer is, well, sure, we can try, but actually those aren't our areas of expertise. And beyond a certain point, you might be better helped with less harm by seeing a specialist, another specialist. Next slide. So MS care does require this interdependent team. No significant task can be accomplished without the help and coordination of every team member. Each team member specializes in different tasks, and the success of every individual is ultimately bound to the success of the whole team. No team member has ever won alone. Now, do you think this is MS related? No, this is actually the definition of team. So as an MS provider, I know that I can't help you win this game by myself. I don't have enough information. But I'm a good coach, which means I know that I need the defensive guy over here, I need the offensive guy over here, and I need the special teams. I'm not going to try to do those things myself. Next slide. So this looks very overwhelming, maybe. Like, look at all of these specialists, you in the middle living with MS. Do you really have to see all of those people? And this is what I would say. I can't tell you how many times in my career I have referred a person to a urologist and they say, I don't really think I need to see one yet. You know, I seem to be, doing better than I was. And, I only have accidents sometimes. And then suddenly that person gets a bad UTI. And we culture that UTI and it comes back needing an antibiotic that, say, is different than what a neurologist is comfortable prescribing. And we say, I think we want to get your urologist involved. And you say, oh, I never saw them. And so now we're looking at 3 to 6 months of a wait time to see a specialist that was already suggested as a part of your team. So my take home point to you guys is get these people on your team. You might not need them now, but when you need them, you really need them, right? You don't want to wait 3 to 6 months for an appointment when now you're struggling. So when the offer comes from your MS provider or your primary care doctor, or if you're a woman, your OBGYN, to see an additional specialist, just go ahead and check in. It's a lot easier and less anxiety provoking to check in when things are, mild than it is when things are severe. And that way, if and when you need them again, you call their office and they say, oh yeah, hi, Mr. Smith. That's great. Let's get you an appointment. You saw Dr. So-and-so 6 months ago. We're happy to see you right now. Instead of, oh yeah, we understand that things are difficult for you right now, but we can't see you for 3 to 4 months. Next slide. So I like to talk about the MS team kind of like a football team. There are many people on it, and I like to talk about your playbook. This is something that you can sit down and do with your support partners or sit down and do by yourself if you find that most valuable. But you want to list a medical team and your support team, like your social support team, and list this team with names, with specialty, with addresses, and with phone numbers. Your healthcare providers that you see 3 or more times a year, and label them that way. Your healthcare providers that you see less than 3 times a year. The pharmacies you use, so your local pharmacy, your specialty pharmacy. If you use durable medical equipment or medical supplies, list those companies. List the medical or health supplies that you buy the most often and where you get them. And those would be vitamins, supplements, catheters, pads, things that you might need for a CPAP machine, things like that. Write down your insurance information, your emergency contact, and then obtain a copy of your living will or healthcare surrogate and keep all of that together in a file. You can even keep it in an electronic file, but I think it's helpful to have a paper copy because we're all password protected. If you don't have a living will or a healthcare surrogate, you can call an MS navigator at the National MS Society and they can help you learn how to get one. Your social support team are the people who are closest to you and help you the most with MS care and support. And that's emotional support, economical support if you need it, transportation if you need it, help with the kids if you have them. List your most fun friends or family members and literally list them that way so that when you're having a bad day and you don't think you can get out of it, you call these people. Here's my list. These people always get me out of this. List your church or spiritual community, and then list the online communities that you access most frequently, including like Facebook groups and things like that. And that's your playbook. Next slide. So part of your playbook becomes learning how to play the game, right? And part of our games right now include telehealth visits. So let's talk about how we set up a good visit. Next slide. George Bernard Shaw, the famous composer, said the single biggest problem in communication is the illusion that it has taken place. So how many of you have left a doctor's appointment where you guys were talking the whole time? You had a very good visit, socially, you know, you felt like you were connected, and then you get to your car and you're like, oh my gosh, I never talked about what I really wanted to talk about. I'm not sure he really heard me, even though, you know, it might've been a fun visit. Next slide. So what can we do to make telehealth better? I'm sure that you guys have watched programs that talk to you about making the most of your telehealth visits before. As I have navigated through the pandemic, sorry, my computer just came unplugged. As I have navigated through the pandemic, we're, you know, about 2 years in, these are the things that I have recognized as causing the most degree of difficulty with telehealth. One is lack of practice. So you get a link from your healthcare provider's office for a telehealth visit, and you never have clicked on the link until just before the visit. So if there's something wrong with access to camera or microphone, you're trying to fix it during the visit instead of before. So always practice the technology and also practice your device choice. So you might not be able to see or hear as well on your phone than you would on a tablet or even on a computer. So think about your device choice and then get help with the view setup. So myself, as a nurse practitioner, I want to be able to see a person move. I want to see you get up and walk across a room, or if you're using an assistive device, I want to see you transfer. I want to be able to see your arms and legs move or not. And so we might need help. We might need a support person in the room for the telehealth visit to move the camera, to show things, so on and so forth. So get help with the view setup. Minimize distractions and noise. And Stuart might be laughing right now, but yes, I did ask my husband to take my son away during this talk because he's a distraction and he's noisy. So minimize distractions and noise if at all possible. And then just like a regular in-person visit, be prepared with a list. And that list is your top 3 to 5 goals or needs for the visit. The benefits of telehealth are that we as your providers get to see inside your everyday life. So we actually get to see where you live. We get to take notice of whether or not there are hazards that might, say, increase your risk for falls. We get to see whether there are lights on in the house, you know, whether you might, and by that I mean, do things look, if you are having difficulty with mental health, does the home feel sad? That's the only way I know how to see it, how to say it. Are you in pain and it's dark all the time? are there support partners around who never can come to in-person appointments, but now they can because they can Zoom in? Or maybe they're in the house. Maybe they have issues with transportation as well. So a benefit is seeing inside your everyday life, allowing in other people who want to be involved in your healthcare, and therefore performing a greater needs assessment. Next slide. Let's talk about emerging therapies in an increasingly complex and hopeful world, which allow us to better satisfy the needs of you living with MS. Next slide. So we currently have about 23 disease-modifying therapies. I'm not going to count them right now. I always miss one. And all of these different categories of therapies listed here have different mechanisms of action. They affect the immune system in a different way. Our interferons and our glatiramer acetate are older foundational disease-modifying therapies. Primarily, they affect the inflammatory response of the immune system. And then our first oral therapies was an S1P receptor modulator. I will speak in brand names for the sake of just recognition of these molecules. So our first S1P receptor modulator was Gilenya. It modulated the receptors S1P1 through 5. And then we have our more modern therapies. Oh my gosh, that is not Mavenclad. That should be Mazent. I will fix that, Bill, and send you a new slide deck before we get this up on the YouTube channel. I don't know if it's possible to fix that, but that should be Mazent, M-A-Y-Z-E-N-T, Zeposia, and Ponvory. So these S1P receptor modulators modulate fewer S1P receptors, and that means that we think they probably offer a better side effect profile. It may also affect the way that they work on the brain itself. Then we have fumarates. We have Tecfidera. We have generic Tecfidera or dimethyl fumarate. We have Bifirtum and Vumerity. So these medications cause a shift from Th1 to Th2 cells by activating this NRF2 antioxidant pathway. They also cause apoptosis of lymphocytes or lysis of lymphocytes. We have teriflunomide or Aubagio, which is in a class of its own, though there is an additional drug under study. It inhibits DHODH, which is an enzyme that causes lymphocytes to rapidly divide. So it inhibits that rapid division. That allows slow division to continue. We have B-cell modulators, Ocrevus, Kesimpta, and right towards the end of the pipeline is ublituximab. These are anti-CD20 cells that result in B-cell lysis. We have our first monoclonal antibody, natalizumab or Tysabri, which blocks T-cell migration into the central nervous system. We have Mavenclad, cladribine, which is in a class in and of itself, at least in multiple sclerosis. It impairs DNA synthesis in T and B cells and results in their depletion. And then we have BTK inhibitors that have yet to be approved, but are in anywhere from phase 1 through phase 3 studies. These pharmaceutical preparations block B-cell activation. They block, therefore, immune complex mediated activation, and they disrupt inflammation and degeneration of the central nervous system. And we're going to talk about them a little bit more as we move through these slides. Next slide. So emerging therapies include ublituximab, which is another anti-CD20, BTK inhibitors, stem cell therapies, and then some other interesting therapies that are, some of which are repurposed drugs from other disease states, and one that's very important to me. Next slide. Ublituximab is an anti-CD20 drug. It was engineered to enhance binding, so it's a little bit different than our current CD20s. It is an infusion. It studied itself versus 14 milligrams of teriflunomide, and it showed statistically significant reduction in relapse rate, enhancing lesions, new and enlarging T2 lesions, and the realization of no evidence of disease activity at years 1 and 2 compared to teriflunomide. It also showed confirmed 12 and 24-week disability improvement compared to teriflunomide. Adverse events were similar to teriflunomide, with the exception of infusion reactions, which were few and far between. So this is an exciting drug that is on its way out of the pipeline. Next slide. BTK inhibitors are quite a buzz because they are a new class of medication. They're named after a physician scientist, and they have been around in the treatment of cancers. Various specific BTK inhibitor molecules have been associated with significant side effects and adverse events. And so over the years, they've worked to make molecules that, of course, are more therapeutic and less harmful. BTK is a receptor. Activation of it causes antigen presentation. And I like to think of antigen presentation as like a waitress comes to you at the end of a meal with dessert on a tray. So this is what your immune system is doing when it's presenting an antigen. Oh, look at all these desserts. And then your body says, oh, I like that one. And it creates antibodies against that antigen. And in the case of sickness, that's good, right? Because if your body sees, oh, that cold, I see that cold, I want to get that. That's a good thing, right? It's going to go around, it's going to find the cold virus, it's going to destroy it. In the case of MS, that antigen looks like myelin. So the body makes an antibody. And then here we are, we're going to go around looking for things that look like myelin to destroy. So when we activate BTK inhibitors, we enhance antigen presentation, we enhance cytokine production, antibody production. These are all things that make the immune system work. When we inhibit it, we reduce these things. So we reduce antigen presentation, we reduce, therefore, B cell activation, and then we reduce the downstream processes as well, including macrophage activation. In the central nervous system, this means that microglia do the right job instead of the wrong job. These medications are being studied in all types of MS. So evobrutinib, femibrutinib, remibrutinib, and orelabrutinib are being studied in relapsing remitting MS. And with the exception of orelabrutinib, they are also being studied in active secondary progressive MS. Tolabrutinib is being studied in relapsing remitting MS, active secondary progressive MS, primary progressive MS, and inactive secondary progressive MS. That inactive secondary progressive MS is the population of people who live with MS for which there is currently no treatment except to continue to manage symptoms as best we can and recommend lifestyle modifications to reduce the risk of vascular comorbidity and to improve brain health. So if this medication shows some good outcome with inactive secondary progressive MS, it could really change the lives of a huge number of people. Similarly, mastinib is being studied in primary progressive MS and inactive secondary progressive MS. Next slide. So now I'm going to talk to you a little bit about hematopoietic stem cell therapies. This was data that was recently presented at the consortium of MS centers. Hematopoietic stem cells are stem cells that are taken from the bone marrow. So we don't, this is not pluripotent stem cells. This is not umbilical stem cells. This is not, these are not stem cells that come from the fat taken out at a clinic or something like that. These studies are dealing with either high intensity or low intensity myeloablation, which means you're given a very strong chemotherapeutic protocol prior to receiving your stem cells back, or you are given a lower intensity chemotherapeutic protocol. In the Canadian bone marrow transplant study, they were given a high intensity chemotherapy protocol. 50% of the people had relapsing MS, 50% had secondary progressive MS, but the average disease duration in both groups was about 6 to 7 years. And the average age were people in their mid 30s. Currently 21 years of research is available, and there's been no evidence of inflammation. That means no MRI changes, no relapses. However, there has still been some disease progression, some disability progression, and that disability progression has occurred mainly in the secondary progressive group. The United Kingdom real-world AHSCT study used low-intensity conditioning, so less chemotherapy. There was a reduction in relapse rate. There were few new lesions. But again, there was a difference in the EDSS score between relapsing and secondary progressive MS, with people who had relapsing MS faring better. What you'll see with these lower intensity conditioning regimens is excellent outcomes, but not as excellent as with the high intensity myeloablation. HALT MS has a 5-year event-free survival of 69.2%. Progression-free survival is better at younger ages and with relapsing remitting MS. And the current BUZZ study, which I think is really going to influence our ability to use stem cell therapies meaningfully outside of clinical trials, is BEAT MS. And they're looking at AHSCT versus our high efficacy DMTs like B-cell depleting agents and natalizumab. The current recommendation is still to rely on these protocols that are being used in clinical trials, rather than spending tens of thousands of dollars at some of our, I'm going to call them neighborhood stem cell clinics, because truly we don't know, we don't have the same numbers of research to tell us that these things work and are not harmful for disease modification. Next slide. So other things to think about. Well, I shortened this list. There are a lot of other things going on in MS therapeutics right now, including hormonal therapies. The thing that I'm most excited about is this molecule called ATA188. It's a T-cell immunotherapy for the treatment of EBV positive progressive MS. So this drug is specifically being studied in progressive forms of disease. It targets EBV infected B cells and their target cells. And basically the point is that if we can destroy these EBV infected B cells, then maybe they won't move on to do the damage that they do in multiple sclerosis. The other thing that's very exciting for me is that listed in the presidential lecture from the Consortium of MS Centers as an emerging therapy is diet. This is incredible. Like, I just got goosebumps all over my whole body. This is incredible. There's actually phases 1 through 3 research going on, looking at various types of diets and looking at them for symptomatic management, but also at MRI targets. And there's now enough evidence. I mean, I've been talking about it for a long time, but there's now enough evidence that an MS provider should be recommending to you a healthy diet as a part of your disease management. The rule in medicine is that you have to prove it. And so we might see what we see, but until it's proven, it's not, it's not truth. And that's science in general. And so finally, we have some proof that this is something that's important. Alpha lipoic acid is being studied and to a larger degree as an antioxidant. Statins are being studied for neuro and vascular protection. So a lot of other things. Statins have been studied for a long time, and the jury was kind of out as to whether or not they were good for MS and whether or not their benefit outweighed their risk for things like liver issues. So we're continuing to study those. Next slide. We also have a movement towards biosimilar agents. And so biosimilars are drugs that are basically the generic versions of biologic drugs. So when a brand name medication loses its patent, it becomes generic. When a biologic drug uses its patent, it becomes a biosimilar. Biologic medications are much more specific and complicated in structure. And therefore there a little bit more goes into whether or not they can become a biosimilar when they lose their patent. FDA studies generic agents from a pharmacokinetic and a pharmacodynamic standpoint to determine whether or not they are as good of a product as the brand name drug. The FDA will only approve a biosimilar product if it has the same mechanism of action, route of administration, dosage form, and strength as the reference product. There was a law passed in 2009 that said that a biologic product may be demonstrated to be biosimilar if the data show that it's highly similar to the already approved biologic product, that there's no clinical meaningful difference in terms of safety, purity, and potency from the reference product, and that is done through these pharmacokinetic and dynamic studies, and that the proposed biosimilar is expected to produce the same clinical result. So what does that mean in MS? Well, currently we do not have biosimilar agents in MS. Our generic MS drugs like glatiramer acetate, Extavia, which is a generic brand name of beta-seron, and dimethyl fumarate are generic medications. Those are chemical products. Whereas biosimilar would be a, quote, generic version of something like Ocrevus, which we don't have yet. So what are the pros? Well, the pros, of course, are cost, we think. The first year a drug becomes generic, it's not always more affordable. And depending on what company is making the generic or biosimilar drug, they don't always drive down the cost. But the National MS Society has been lobbying for a long time for biosimilar agents because of the incredibly high cost of MS therapeutics. However, what we have to think about is whether or not biosimilar generic is enough for a person living with MS. So these biologic agents are incredibly complicated. And even if the FDA is following their rule that says something has to be between 85 and 125% as effective as the original biologic agent with a 90% confidence interval, it's pretty specific. There might be something in that biosimilar molecule that you're sensitive to. Maybe it's a salt, maybe it's a preservative, but that could make a difference for you. And this is what we see in medications that have what's called a narrow therapeutic index, like anti-seizure medications, anticoagulants, even antidepressants. Another con is that there is such a thing as an interchangeable biosimilar or an interchangeable generic. And interchangeable drugs come from companies who've done additional studies that go beyond proving the safety, purity, and potency from a pharmacokinetic and dynamic standpoint. And they actually do an additional study in humans, like maybe they look at MRI or maybe they look at relapse rate. They spend additional time and money to do more to prove that their product actually is interchangeable. So I hope that we see the right biosimilars come to market so that our MS care becomes more affordable. Next slide. Okay, so now we're moving on to why behaviors matter, why yours matter, and the importance of lifestyle and MS management. I think I have about 10 more minutes, and then we'll take questions. So lifestyle and the immune system go together. It's no longer a myth that physical and mental stress cause inflammation in the body. And that inflammation, that low-grade inflammation, can be modified by nutrition, mindfulness, and movement. Next slide. All right, so how does Humpty Dumpty fall off the wall? How do you become, how do you have a disease or a medical condition? Well, some of it has to do with choices, and some of it has to do with things we can't control. So choices we make come from our environment. They come from what we maximize, minimize, and prioritize. And then we have our genes. The problem with our genes is that they don't always turn on, but we can turn them on for sure by making poor choices. These choices that we make that interact with our genes then affect our hormones, our immune system, our nervous system, our digestion, our metabolism, and our ability to get rid of things that we're exposed to. And if some of those things are messed up, then it could throw us into illness instead of staying into wellness. So our cup overflows and Humpty Dumpty falls off the wall. Next slide. So let's talk about nutrition. Next slide. So one of my basic tenets is eat food, not too much, mostly plants. Michael Pollan said it. It doesn't mean you have to be a vegan. It just means that these foods over here on the left and top side of the slide are much, much better choices than the foods on the right bottom part of the slide, which basically have very little nutritional value. They're inflammatory, they're full of chemicals, they're highly processed, and they cause inflammation. Next slide. Dr. Alana Katz-Sand presented this information at our annual meeting at the CMSC 2 weeks ago. She talked about the specific science behind various reactions and chemicals that occur in foods. So receptors from foods high in fiber and omega-3s stimulate anti-inflammatory effects, as do flavonoids that are found in colorful fruits and vegetables. Short-chain fatty acids are made in the gut when you eat high fiber foods, and these short chain fatty acids produce actually anti-inflammatory chemicals. Foods high in polyunsaturated fatty acids are anti-inflammatory, and in animal models, these actually provide evidence for neuroprotection. Higher levels of intake of fruits and vegetables are associated with reduced rates of relapse in MS and also with lower levels of disability. Foods high in fiber from whole grains, fruits, and vegetables activate receptors that decrease the recruitment of inflammatory cells and proteins. Saturated fats are pro-inflammatory and increase inflammatory chemicals in the body. Long-chain fatty acids from processed foods, seed oils, and foods high in omega-6 stimulate T cells to become inflammatory instead of anti-inflammatory. And saturated fats, foods high in omega-6, and sugar increase the risk for vascular disease. And I've spoken to you multiple times today about what vascular comorbidities do to MS. They enhance your risk of progressing to an EDSS of 6 by 6 years sooner. That means in a wheelchair. Next slide. Exercise. Let's talk about exercise. I don't like to talk about exercise so much anymore. I like to talk about the word movement. So exercise is associated with the production of BDNF, brain-derived neurotrophic factor. It's neurotrophic and it may be neuroprotective. It may help reduce that inflammatory response, and moving our bodies is cheap, right? And usually harmless unless we're trying to do too much. So I always try to encourage people to be under the care of either an exercise specialist, of either an exercise specialist or a physical therapist that knows their body and understands multiple sclerosis, including fatigue and heat sensitivity. Exercise is associated with a decreased risk for vascular disease and also improved vascular disease if you already have it, and it improves mood. So it really lets your body release those feel-good chemicals. Next slide. It's important to choose forms of movement that you like. Aim for about 22.5 minutes a day. That gets you to your goal of 150 minutes a week. And you can split up that exercise if you need to because of fatigue or because of your schedule. Make sure you stay cool and make sure you get help if you need it. And that would include an accountability partner. It's a lot more fun for many people to exercise with someone else, to move their body with someone else, than it is to do it alone. Next slide. Mindfulness. Next slide. So I made this. It looks kind of silly, but it's really meaningful to me. We are, as my husband says, I'm just a simple caveman. So in the days of the cavemen, we elicited a fight or flight response when we're running from the lion or running from the tiger. And as soon as we got away from the tiger, we calmed down, right? So we're not meant to be always running from the tiger. And today's lifestyle keeps us running from the tiger. So here we have this guy. He's drinking coffee all day to stay up at work because he's got a baby at home that keeps him awake at night. And then he drinks beer to go to sleep. He's still trying to exercise an hour a day. He sits in traffic angry because he's listening to the news. He's worried about money. When he's not at work, he's on his phone or working on his computer. So you can see this vicious cycle. This guy is always in fight or flight. And what does that do to him over time? Well, it tips his bucket, as my 5-year-old said. Next slide. So this guy, initially, when he starts off with, the crazy busy job and the 2 kids, he's in this like yellow zone, right? Like he might start to feel that things aren't working right in his body. He might start to either gain a little weight or, feel a little anxious. And if he recognizes it soon, he can come back into the green zone, which is resting and digesting, right? No more fight or flight. But if he continues, he'll freeze. And when you freeze, your body basically decides from a simple caveman point of view that it's done. Like, we're going to die if we continue like this. Now, I am exaggerating right now. I'm being a little bit sarcastic. This man isn't going to literally die if he continues on that path, although he might eventually have multiple medical conditions, probably a heart attack, maybe an inflammatory disease. But if he continues on this path, his body is going to do everything it can to keep him alive, which means his metabolic rate's going to go down. He's going to hold on to weight. He's going to be sleepy a lot. He might withdraw from social behavior. So we don't want to do that. We don't want to always be running from the tiger. We want to stay down in this green zone. Next slide. So mindfulness is one of the ways that we can do that. So is moving your body in a happy and reasonable way, and so is eating healthy. Meditation improves the immune response without an increase in inflammation. So boosting the immune system isn't always a good thing, but mindfulness does it the right way. It stimulates activity in the areas of the brain that help control emotions and also help the immune system function better. It results in decreased fight or flight, really results in decreased inflammatory factors that have all been implicated in multiple sclerosis, and increased anti-inflammatory factors. Next slide. So how do we do it? Well, I've talked a little bit about how we do it with healthy eating, with moving your body, and maybe with meditation, maybe with a breathing exercise, maybe with positive affirmations, maybe with prayer. But we also practice mindfulness in the way we take care of ourselves, and that includes our MS care. So keeping regular checkups with your MS provider, getting surveillance MRIs, talking to your doctor's office if you have new symptoms or you're noticing disability progression, talking to your doctor if your disease modifying therapy doesn't seem to be working for you, or if you're having side effects. Similarly, your symptom management medications. Do you need a rehab tune-up? Has it been a while since you've seen a physical therapist and maybe you're noticing your balance is different, or maybe you want to embark on a new exercise program and want to do it safely? Do you need any more people on your team? And are your other medical conditions well controlled? Next slide. Supplements. Can move forward. So supplement safety is a big thing, and that's really going to be the crux of what I say today. Americans spent an estimated $227 billion on nutraceuticals in 2020, and most of these nutraceuticals have very little evidence that they help what people are taking them for, and certainly very little work or what's the word I'm looking for? Information around the potential for adverse events, including drug supplement interactions and supplement disease interactions. So what are the benefits of supplements? Well, you get fruit and veggies in a pill, and you don't like to eat fruit and vegetables. But actually eating fruits and vegetables causes chemical reactions to happen in your body that don't happen when you're taking them in a pill. There is more evidence for certain supplements in certain conditions than most people know. I have 4 or 5 textbooks that are specifically for vitamins, minerals, botanicals, and herbs that list the evidence for the things for which they're recommended. But the danger is that not a lot of people know what that evidence is. Not a lot of people take the time to study it, particularly in conventional medicine. Supplements aren't regulated for consistency. Quality is a concern. Like I mentioned earlier, you can't replicate the benefits of food. And either you're getting no advice, poor advice, or you're talking to someone who has inadequate knowledge. Very, very important to talk to someone who has adequate knowledge, not only about supplements, but also about the medications that you take and the conditions that you have before you spend any money on something that makes a claim. Next slide. So support your immune system simply and safely. Optimal health is not complicated. Maximize what you need to put in, the good things, minimize the bad things, so take them out, and then prioritize your health. So prioritize the things that you need to stay healthy, happy, and out of fight or flight. Next slide. So this is my guy, Dane, at the Consortium of MS Centers with me. I love this picture so much. So I hope it makes you smile. The Dalai Lama said, "What is the meaning of life? To be happy and useful." I feel like I am happy and useful in my life, and that is very meaningful to me. So thank you for allowing me to be here and present this to you today. And I think we're right on time.
We are right on time. Thank you very much, Megan.
You're
Hey,
welcome.
everybody, give her a round of applause virtually. Yeah, I can hear you from wherever you are in the United States or around the world. I can hear you clapping as well. Thank you, everybody. And thank you again, Megan. We're going to begin the Q&A, all right?
With all the different medications they offer now, why are they like offering like different parts of your body? Like one's for T cells, one's for myelin, one's for something different, one's for this. Why not everything? I mean, it seems like they're, instead of they're trying to fix us, it's like they're trying to do other things. You know what I mean?
I do, and I think that's a very good question. So if a molecule that was developed that eliminated your T cells, your B cells, and all of the downstream effects, you'd be dead. So because you would have no immune system. So that's why, for example, people with cancer who are given really strong chemotherapies have to be kept away from certain foods. They can't have live flowers near them. They become what's called neutropenic, and their risk for infection is so very high. In multiple sclerosis, we have been unable to identify a biomarker that tells us that X, Y, or Z drug would be the best drug for you to take. And so we continue to try to modulate the immune system in specific ways, which is difficult since we don't know the cause. That's why taking the vitamin D research is so exciting. That's why this molecule ATA188 that's specific to EBV positive B cells is so exciting. So we continue to try to identify the cause and have a very targeted response. But then there are also therapies that have a broader response, and within that broader response, hope to provide lesser risk to your immune system. So I hope that answers the question. Let me see if I can give you an analogy to a different disease state. Maybe with cardiovascular health. We learned years ago that giving a person a beta blocker after a heart attack prevented mortality. But that beta blocker might not be the best choice for their blood pressure control, even though it's a blood pressure medication. So, we just don't know everything, but I don't think anyone's trying to hurt you. I think the bottom line is that when therapeutics are discovered, they're trying to do the most benefit with the least harm.
Is the dosage of statins being studied the same as the dosage for high cholesterol?
I have no idea. I would have to Google that, and I'm happy to do that while we talk.
First online question is from Nicolette. Did, I can't even say this, ublituximab actually improve disability or just make it less worse? Oh my gosh.
Less worse. No, that makes
less
sense.
Worse.
So in these 12 and 24 week epochs, there was an improvement in disability. And so what that means is that in any period of time during the clinical trial, for a 12-week period, sometime in that period of time, and or for a 24-week period, sometime in that period of time, people on ublituximab experienced more clinically definite improvement.
Okay, thank you for that. Next, a person is asking, how long can you stay on Ocrevus?
Well, I don't know, because people have not been on it for lifetimes. I think that we're learning more about how we do things long-term with the medication. But as far as what we know from open label extension trials and safety, and also the use of Rituxan for long periods of time, which is a similar molecule, just not humanized. At this point, we would keep a person on ocrelizumab until we felt their disease no longer needed to be on that medication.
Okay, thank you for that. Going further, is there an end life to any of the MS medications being used by a patient?
What does that mean, an end life?
I don't know. I'm only reading it. So I don't know. Maybe similar to what you were just saying, that...
okay, that makes sense. So yes, there's an end life for every MS medication for a person living with MS, and that is when and if the person has a serious adverse event that warrants stopping the medication. If the person is asking specifically, do I need to be on this drug forever? I can speak to DISCO MS, which is the study that looked at stopping disease-modifying therapy at age 55. So this research was also presented at CMSC a couple of weeks ago. Excuse me. And it was designed as a non-inferiority study. And what was found is that there was no difference in relapse rate or MRI changes in people who stopped therapy versus people who stayed on therapy. However, when you look at the numbers, people who stopped therapies, awesome, bud. people who stopped therapies had more relapses and more MRI lesions. So the result of the study from a statistical standpoint was inconclusive. There are 2 other studies that are currently in process that are not non-inferiority studies. So they might be a little more helpful at advising us when and if people can stop disease-modifying therapy.
That's great. So essentially, though, once they're on a therapy, they should always be on their therapy, unless, of course, they pass.
Well, or until one of their, until their MS provider says, maybe we should try to stop this. You haven't had lesion progression for a long time. You haven't had relapses for a long time. But the irony of that is it's probably because of the drug. So the point of these studies is to answer just that question. If we make a recommendation, do we have the evidence to confidently say more people who stop their medications after X age do better? Their MS, quote, burns out, so to speak. We don't have the answers yet. I have the answer to that statin question.
Okay.
At least this is a quick glance at clinicaltrials.gov. Both simvastatin and atorvastatin are being studied in doses of 40 milligrams. Now, there are pages of studies, and I didn't look at everything. That was just what I saw quickly.
Okay, thank you. Another Renee is asking, what is the healthy diet to follow with multiple sclerosis? I think you just spoke about this, though, yes?
Yeah, so I actually, I did on your channel. I have multiple
I know.
hour-long talks specifically about that on your YouTube channel. So I would encourage you to take a look at those. The right diet for MS is the one that you will follow. And so many people say, oh, I know what a healthy diet is. I'm going to go ahead and follow that. Other people say, I want a book and I want a plan. And so that book and that plan depends on what you're willing to eliminate from your diet and what you're willing to keep in it. And so if you want to focus on a plant-based whole foods diet that's high in omega-3s, then a good Mediterranean diet is good for you. Check out the longevity diet if you need a book. If you want to eat more meat and you're willing to become gluten, dairy, and egg-free, then check out the Walls Protocol. If you want to be a vegan and eat a very low-fat diet, check out the McDougall Protocol. But currently, we don't have evidence to say that there is one right diet for MS, and that's beautiful, right? Because we all like to eat differently. We all have our own things wrapped around food, mentally, emotionally, culturally. So choose the healthy diet that you like to eat, because eating should be enjoyable.
Okay, great. And for anybody that doesn't know, on the MS Views and News YouTube channel, if you go to the search box and you type in either diet or nutrition, you'll see many, many videos pop up that you can follow and learn from them as well. And Dr. Terry Walls was on there as well. She did an interview with me several months ago, and she will be back on again with me in the fall as well. And Megan has done many talks for us, so you'll find them all there. All right, next person, a Kimberly, is asking, what can I do? What can I do? Just had first relapse in over 5 years. My legs feel as though they are not their own. By the way, Kimberly, Megan cannot answer you as your doctor, so she can only answer this in general. But continuing, she says her doctor appointment is next week, whatever a fusion and the follow-up. So what can she do for her legs, I think is what she's asking.
Yeah, so I would ask your doctor for a referral to physical therapy. I would make sure that I don't know where you live, Kimberly, but I would make sure that if it's really hot right now, that you're using cooling equipment, a cooling vest, or a lot of people like a wrap around, like a lumbar support gel ice pack. People use them for back pain, but they're very transmittable to using to keep cool for MS. So those are the things that I would talk to your healthcare provider about.
Thank you for that. Next, Kimberly's asking, can you discuss the benefits of alpha lipoic acid?
Yeah, certainly. So alpha lipoic acid, specifically in MS, has been shown to in secondary progressive MS, reduced disability progression. This was in a really small study, and currently a larger study is underway. The benefit of the larger study is that we're also starting to see that there might be adverse events associated with alpha lipoic acid. One of them is renal disease. So it's important not to just willy-nilly take a supplement. That brings me back to the supplement safety thing. But alpha lipoic acid is a very potent antioxidant. And so what we do the worst job at in MS therapeutics is slowing down disability progression. We're really good at reducing relapse rate. We're really good at reducing lesion progression. But perhaps it's these other things that we can get from healthy lifestyle changes that actually are the things that slow disability progression. So alpha lipoic acid, super strong antioxidant. Other super strong antioxidants are colorful fruits and vegetables.
All right. Can MRIs ever be wrong or misleading to a neurologist?
Certainly. I mean, MRIs can't be wrong because they're a picture of something that's real. But the interpretation can be wrong, and the interpretation has to be made in conjunction with the clinical picture. So the history of the patient, the physical exam of the patient, and any ancillary tests.
Great, thank you. Next one. Please discuss the etiology of MS as it relates to age of onset and or gender.
So the average age of onset of MS is between 18 and 50. The more women than men have the disease. It's thought that between the ages of 18 and 50, that's when our immune systems are the most robust. So they do the best job at keeping us healthy. But if there is a mechanism either from the environment or from genetics that's going to turn the immune system the wrong way, it's probably going to happen in that period of time. In women, we think it might have something to do with hormones, but then the hormone estriol, which is the pregnancy estrogen, actually keeps MS quiet when a woman is pregnant. So not quite sure there. I hope that answered the question.
Okay, I hope so. All right, next one. It's a long statement and question. I've had MS since 86 and 58 years old. I have not been on any DMT, have had relapses many years apart, 17 first years, 6 due to gallbladder, whatever. All right, next. I have primarily a good diet and exercise regimen. Should I be considering a DMT this late in life as our immune system decreases with age? Question.
Yeah, so we don't know if your immune system decreases with age. So one of the things that goes into that equation is biological versus chronological age. So for example, a 50-year-old man who follows a very healthy diet and exercises and minimizes his stress and is happy with his life, probably has a biological age of 40, 45. So younger than his chronological age, which means his body works more like that of a 45-year-old than of a 50-year-old. If this person is still having relapses, still having MRI changes, and noticing disability progression, then I would argue that he needs to be on a disease-modifying therapy. One of the greatest prognosticators of mobility and cognitive loss later in life with MS is the burden of white matter disease. So it also has to do with, does he have brain atrophy? How many lesions does he have? So those would be questions I would talk to his healthcare provider about.
Okay, thank you. Next, how often should I go for physical therapy, occupational therapy for a tune-up of sorts?
I would say whenever you notice that things just aren't quite right with your body, it's not a prescribed thing, but if you notice that you're having a harder time doing things around the house, you're feeling slower, any changes like that, those are things that you should bring up to your MS provider that would warrant investigation. and a tune-up, so to speak.
Okay, thank you. All right, and for everybody to know, I keep saying I. This has nothing to do with I being me, all right? These are questions that I'm reading from online. I just don't want anybody to think that I'm complaining all the time. All right, next person writes, I have PPMS and severe migraines. What are the best strategies for managing both?
I don't know, because I don't know what your PPMS symptoms are. So one of the best strategies would be to make sure your symptoms of PPMS are managed with lifestyle, medication, and rehabilitation, making sure that you have the support system that you need, and that your other medical conditions are well managed, which brings me to migraine. So staying well hydrated, getting good nutrition, staying on the same sleep schedule every night, those things can be very beneficial for migraine. And then talking to your healthcare provider about either ways to manage migraine with lifestyle, with supplements, or with medications.
Thank you. Next, a little complicated. Cindy writes, just as EBV correlates significantly with MS, I wonder if COVID virus will eventually be found to correlate to yet another chronic disease. I'd be interested in your thoughts that you might have.
Yeah, that's a very interesting question. I think it's something that we're asking because of the post-acute COVID syndrome that looks a lot like the chronic fatigue that we see from Epstein Barr. I will say that as an MS community, we thought that we would see a lot of disease activity in people who live with MS who have COVID, who had COVID, whether or not they were on disease-modifying therapy, and we didn't. So, we were sort of ready for relapses and we didn't see them. I don't know what that means. My personal feeling about it is that COVID has given sociological, medical, rehabilitation, and anthropological graduate students enough food to fill up dissertations for decades.
Good. Thank you. Next, how long, well, no, we already did that. Which drug is best for relapse remitting?
I can't tell you because they haven't all been studied together or versus one another. So you really can't compare apples to oranges. It's more like comparing apples to carrots. So the right drug for relapsing MS is the one that you feel comfortable taking, that you're going to adhere to, that you're going to be diligent about the monitoring for, and that you and your physician come to a shared decision is going to be the best at controlling your MS.
Okay, thank you. Next, a person writes, I'd like to better fully understand a relapse. Can you tell me what it entails?
Absolutely. I think that's a great question. People who've had MS for a long time often need a refresher, and people who are new to MS need to know what it is. So a relapse is also called an exacerbation or a flare. And it is the rather sudden onset of a new neurological symptom that you've never had before that lasts more than 24 hours. And some people would say more than 48 hours. And so an example would be you wake up in the morning and the vision in your right eye seems kind of off. And as the day goes on, it gets worse. You wake up the next day, it's still the same. And so you call your neurologist. Another example would be weakness or numbness on one side of the body or in your legs, difficulty with coordination. And these things can sometimes evolve over hours. Things that come on, boom, suddenly like that warrant emergency medical evaluation because of the possibility that it could be a TIA or stroke. But in general, an MS relapse will kind of evolve over 1 to 2 days. And it is not related to something else. So many folks living with MS will say, well, I have relapses every week. And then when you question them more, what they really mean is that they have like a few good days every week and the rest of the days are bad, or their spasticity really bothers them a couple days a week, or their fatigue really bothers them. I had a relapse that was 2 weeks long last month, and it was really just an increase in fatigue because they were more active, or maybe an increase in spasticity because they had a urinary tract infection, not a new neurological symptom. And so a pseudo relapse is that it's an increase in symptoms that you already live with from MS because of something else, an infection, stress, lack of sleep, maybe a medication side effect, maybe whooping it up at your cousin's wedding. So a relapse is something that makes you go, oh, wow, what is going on? This has not happened to me before. It's treated with steroids, rehabilitation, ways to manage the symptoms. Most people with relapsing MS completely recover from relapses early on in the disease.
Okay, thank you for that.
Mm-hmm.
All right, next we have, do no additional lesions on the MRI mean that MS has not progressed?
Yeah, so we talk a lot about relapses and we don't talk a lot about remission. So if you are living with MS and you have no new lesions on your MRI from one scan to the other, you haven't had relapses in that period of time, and you haven't had disability progression or progression of your symptoms, then you're in remission for that period of time. It's exciting.
Okay, thank you. Next, about biosimilars. Is it true that biosimilars do not have the same sequential ingredients or secret source as the true formula?
No.
Secret sauce.
Secret
Source, not
sauce. So
source.
no, it's really complicated. Even for like me as a medical professional to read the way that they calculate whether or not something is 85 to 125% as the same as the parent drug, and then the confidence intervals. What's different about what may be different about biosimilars and generic medications is that they use different, like there may be a salt or a preservative that's different. Now that might be meaningful for one person and not for another. There's no way to know that. But that's one of the worries that we have in MS about biosimilars. If they don't do additional studies in humans to prove that they reduce relapse rate, slow MRI, reduce MRI changes, instead of just doing the pharmacokinetic studies in a lab. So it is a lot more specific. Let me rephrase that. There are many myths around generic and biosimilar drugs, and I would say that they're made as safely as possible, and they have to have the same major ingredient. There's a great, really a couple pages on the National MS Society website with links directly to the FDA website about how they study generic and biosimilar drugs. So for all of those details, I would refer you there. You can just go to nationalmssociety.org and type in biosimilar to the search bar.
Okay, thank you. Next,
Yeah.
I'm going to read to you from, this came in, it was on Twitter. All right. Why is natalizumab not licensed to treat progressive MS? New data shows that natalizumab has an impact on chronic active lesions and indicates that natalizumab, also known as Tysabri, is a potentially effective treatment for smoldering MS. So then, why can't we use it?
So if the research is new, then it has to be submitted as a new indication to the FDA. And that's why there's not that indication. It takes time.
Okay, thank you. Next, we have, what are the future treatments for secondary progressive MS?
I would refer you back to the slides that I showed. I think some of the most promising future treatments for secondary progressive MS are a couple of the not a couple. A couple, no. one, two, three, four, five out of the 6 BTK inhibitors, and also the ATA188 molecule.
Okay, thank you.
Yeah.
All right, a few questions remain. Long-term relapse remitting, 30 plus years, no change in MRI, but other changes. I noticed resulting from MS damage to CNS. What is MS, and what could just be, could it be just MS, or could it be just getting older?
It's probably a combination of the two. And because of that, it's important to make sure that all of your bases are covered. I don't know if this person is a woman or a man. I don't know how old this person is. So she could be 50. If she's had MS for 30 years, she could be 70. But depending on age and depending on sex, you might want to talk to a primary care provider about exactly what your symptoms are and whether or not they could be related to hormonal changes of aging. If you're having trouble with cognition, as you get older, it's super hard to tease out, but there are patterns that are indicative of things related to MS and patterns indicative of things related to neurodegenerative dementias. Those things can be figured out by neuropsychological testing. Making sure that you've been to your primary care provider and have had a good lab workup this year to look for thyroid issues, B vitamin deficiencies, any other insufficiencies of nutrition might be worthwhile. But even if something is related to aging rather than MS, it doesn't mean that you have to deal with it if it is uncomfortable. So I would definitely pursue, I would pursue that path to try to feel well.
Okay, thank you. We currently just show 4 more questions remaining online, and unless somebody has something in the audience, then we're going to be finished in 4 more questions because we don't have time to go forward from here. All right, next one, interesting. After 12 years of being on Copaxone, the neurologist had me stop April 22nd due to having started reactions when injecting, chest heaviness, sobbing, pounding in the heart, pounding in the head, heart palpitations lasting about 20 minutes. Discontinued the Copaxone, told me she would see me again in November to discuss another DMT. MRI was scheduled for June 22nd. How long, though, is it safe to go without taking another DMT? Because I don't want to relapse.
That's why you have an MRI scheduled for June 22nd. So what it sounds like what the neurologist is doing is looking for subclinical disease activity. Assuming that this person hasn't had a relapse between April and June, the neurologist wants to see that nothing's changing in the brain. So a lot of this depends on, again, her age, how long she's had MS, what her disease severity has been like. Maybe they've had conversations about, do you want to go on another disease-modifying therapy or do you want to wait and see? So the safety of staying off depends on all of those things. It also depends on the mechanism of the drug and how long it stays in the system, so to speak, how long its effect on the immune system remains, and how the disease was prior to taking the medication. For example, a person who's been on Ocrevus for a long time, whose B cells stay depleted, may be protected for longer because their B cells are still depleted. And so, that's why we look at MRIs if things don't show up in someone's body. Meaning like, I'm having a relapse. What do I mean by that? Sorry.
You okay?
Yeah.
Okay. Why do symptoms linger when lesions resolve on MRI? What is resolving?
So if you're referring to a relapse, as the disease progresses, you have less reserve. And so there is incomplete resolution of relapses. If you're referring to, well, and that must be what you're referring to. So lesions are plaques or scars, and the brain, the nervous system has to figure out a way to work around them. And at some point, it can't, just because of the disruption of the nervous system and the damage that's there.
Okay, next one, sorry.
Okay.
What does it mean when you have atrophy of the cerebrum, no brain lesion, and lesions on thoracic and cervical?
I'm not sure, not knowing the rest of that person's clinical history. You could have transverse myelitis, recurring transverse myelitis, NMO spectrum disease, MS, any number of MS mimics. I don't know how old this person is and what other parts of their life or exposures might have caused brain atrophy. There's many things that differential could hold.
Okay. All right. What if a person has had, I'll just read it as a person. I had no change in MRI pictures for 20 years, but my EDSS has increased from 1 to 7 in that time. I've read about measurement of neurofilaments being more useful in some ways than in others. Can you tell us more about this?
Certainly. So neurofilament is a protein that can be measured in the spinal fluid and the serum. I am not sure that neurofilament is available commercially yet. The last time I checked a couple of months ago, it was not, but something tells me it is now. I could be very wrong. And neurofilament levels are higher before and during and after a relapse. They're higher in people with progressive MS. They're also higher in people with other neurological conditions like traumatic brain injury. They're also higher in people with diabetes and obesity. So as much as excited as we all are about using neurofilament as a marker for disease progression, like, wouldn't it be nice to just get a blood test instead of having an MRI, certainly cheaper. There are a lot of confounding factors that still have to be teased out about age, sex, and disease matched controls compared to people with MS. So it is exciting. What we do know in MS now is that neurofilament levels are higher in people with progressive disease and around a relapse.
Okay, last question, all right? Last question. I am currently on Ocrevus for 2+ years following the birth of my son, and disease has progressed significantly. Have you ever experienced this with others?
Yeah, there are a few people I've taken care of who have had disease progression on Ocrevus, particularly in the first 2 years. There's 2 ways to look at this. One is to consider a drug with a different mechanism of action. I would say 3 ways. 2 is to reconsider the diagnosis. And 3 is to consider that Ocrevus is really a long-term medication, meaning that the longer you're on the drug, the more, the better the management of the disease becomes. So people get frustrated with Ocrevus because they've received a year's worth of infusions and nothing's changed for them, or maybe they had an MRI lesion pop up. But we have to remember that the clinical trials in Ocrevus that showed the benefits of the medication, including the percentage of people that had clinically definite improvement, were at 2 years. And then as you look at their longitudinal data, their phase 4 data following the clinical trials, you see more of that as time goes on. I don't know the specifics of the numbers of that, but it is a medication that I've encouraged people to stay on, depending on the severity of like this person's disease progression, and also, is this the right drug for her body?
Okay, thank you very much, Megan.
Yeah, you're welcome.
That was awesome. Thank you. We like seeing Dane as well. So tell him I said hello, please. All right, and have a great day. All right, but everybody, thank
you.
Megan for being here today.
Okay, bye guys. Have a
Bye-bye.